these are bluebells, and 50% of the worldwide bluebell population is actually in the southeast of England. This is on Shotover Hill, where I walk my dog in the mornings. So, right, okay, off we go, hopefully. So essentially, CLL, although it's called a leukemia, it's actually classified as part of the lymphomas. And we always say that it's the most common leukemia in the Western world, but in terms of lymphomas, there are many other lymphomas. And the reason why I want to highlight this here is not so that you learn them by heart, all the different types of lymphomas, but it's essentially, so that you realize, I don't know what, that you realize that there's so many different types, and that when you just go onto the internet and you start Googling a leukemia or lymphoma, that you will get into trouble, because we have over 100 different types of lymphomas now in the WHO classification. All of them have got slightly different prognosis, well, very different prognosis. They are treated in a different way, and some of them are have a very serious prognosis, whereas others, like with CLL, you can obviously live for years and years without even maybe requiring treatment. So it's very important to understand that, and it's also the reason why it's generally hematologists who treat these type of blood cancers. So how do we classify the lymphomas? Again, just so that you're a bit aware of it. You don't learn this by heart. This is sort of medical student level, but it's really important to realize that there are different types of lymphomas. There's non-Hodgkin's lymphomas, of which CLL is part of those, and they are classified into B and T cells. So basically, we've got lots of white cells in our blood, and they all fight infections in different ways. Some of them are called neutrophils, and they fight serious infections like bacterial infections. And then there are some that produce antibodies, or in some way are involved in producing antibodies to respond to infections. And those are the B cells. And then the T cells, they usually stimulate the B cells to produce those antibodies. So the message I want to get across is there are different type of white cells, neutrophils, B cells, and T cells. And CLL is part of the B cell malignancies. And within the B cell malignancies, there are lots and lots of them. Some of them are high grade, and some of them are low grade. And the high grade ones are very often, respond very well to chemotherapies, and they can be cured. Whereas the low grade B cell malignancies very often cannot be cured. But then very often they don't really progress very much, and you don't need any treatment for them. And CLL is the most common form of these type of low-grade B-cell non-Hodgkin's lymphomas. So that's how we are kind of classifying in our heads the different types of diseases that are out there. And as I said before, this is just a fraction of them. There are over 100 in total. So the low-grade B-cell non-Hodgkin's lymphomas, of which CLL is one of them, they usually progress very slowly. Sometimes patients don't need any treatment. Their patients can live for many years without needing any treatment. The treatment is variable, but usually these days it includes a combination of chemotherapy and some antibody treatment like rituximab. And if they're very early stage patients, then we would also sometimes consider radiotherapy. So these types of lymphomas, they are never seen in children, and they are really diseases of usually of patients who are, I always say, over the age of 25. Usually, as I said, they're considered as being not curative with chemotherapy. And very often, because they are cancerous diseases of the lymph gland tissue and of the immune system, they make the immune system go funny. And so some of you as patients might have experienced this when you get what we call autoimmune hemolytic anemia, or we get immune thrombocytopenia. So your own body starts producing antibodies against your own red cells or your own platelets, and that then causes problems. The other problem we see with the immune system, again, you might get increased infections, and that's the other problem, is that the immune system, the normal immune system, doesn't work 100% because the CLL is a cancerous disease of the lymph gland tissue. And so that causes problems with the immune system in general. And that's a feature of all these low-grade B-cell non-Hodgkin's lymphomas. So CLL effects on one slide, as I already mentioned, it is a cancer of the immune system. It consists of abnormal lymphocytes, B lymphocytes. It's the most common leukemia in the West. It's more common in older patients. Patients therefore frequently have got other health problems, and so it might be more difficult for those patients to tolerate very intensive therapies. And so as clinicians, we always have to bear that in mind and essentially, in our mind, together with the patient, establish a risk-benefit profile before we decide on any type of treatment. Very often they're associated with immune deficiency or other problems with the immune system. And the main thing with these diseases is that they're really very heterogeneous, and that some patients go on for a long time and not needing any treatments, whereas other patients, despite the best treatment, they will experience one episode of remission where the leukemia can't be detected anymore, and then they relapse, and then they need more treatment, and so forth and so forth. So traditionally what we've seen with chemotherapy when we treated CLL patients with chemotherapy is that the durability of the remission, which is the time where you don't need treatment, basically decreases over time. And at the same time, the quality of the responses, so that the depth of the response goes down, and the complication rate increases. Because in the olden days, when we gave one chemo after the other, one chemo course after the other, when patients were relapsing, obviously we were damaging the immune system even more by giving all this chemotherapy. And we're also inducing, more sort of clones and abnormal CLL cells because of the chemotherapy that then led to resistance, of the chemotherapy. Those are sort of concepts. They have been half proven and not completely proven, but I think in our mind, that's how we think about CLL as being a disease that will, not be cured with chemotherapy because it's able to escape from chemotherapy all the time, and that's by that I mean the conventional chemotherapy. So the other thing that you might have come across in your reading is this immunoglobulin mutation status. So when you're, traditionally we know that when you're unmutated, you've got unmutated CLL, then as a population, you behave differently from patients who are hypermutated. And we really think that these are two different types of CLLs. But to be honest with you, I keep thinking that every CLL patient has got his or her own CLL disease, and that every CLL is different. So these are very crude, it's a very crude way of classifying patients into a group of patients that might be doing not so well and another group of patients that might be doing a lot better. I personally, and most other clinicians, don't use these tests on individual patients to identify prognosis of individual patients, because the predictive value, on an individual patient is just not good enough. And it's a good way of looking at clinical trial populations when you've got lots of patients together, but it's not really a good way of identifying the prognosis of an individual patient, which is why, in actual fact, none of the markers that we've studied in the last 40 years that looked at prognosis have made it into the clinic. And so when you go and see your CLL doctor and you for the first time, you'll be surprised that very few markers are being used. I did a literature search once, there are over 1,000 of them, but actually we're using none of them in the clinic because they're not predictive enough to be useful in an individual patient. So how does CLL present? Well, when you quite often these days, especially in the developed world, it presents as just an incidental finding. So you go to your GP with something totally unrelated, back pain or whatever really, and then the GP does a full blood count and realizes that you have got a lymphocytosis. And then other tests need to be done in the lab, in particular flow cytometry, to confirm that that this is a CLL and not just a reaction to an infection, because lymphocytes fight infection, so you might get a lymphocytosis for other reasons. You might not even notice that you've got an infection. Some viruses you just have and you get a reaction. So it's always important to actually to confirm the diagnosis of CLL by flow cytometry. We do this routinely in the laboratory, so the GPs don't even request the test. We just see that there's a high lymphocyte count then we usually ask for a repeat sample a few months later, and then we do the flow cytometry. And so that's how the GP then diagnoses the CLL. Sometimes patients present with B symptoms, and by those we mean weight loss, night sweats, drenching night sweats, fatigue, and sometimes itchy skin. Some patients also have got recurrent infections, and they present in that way because they do get one infection after the other. And then quite rarely, actually, in the developed world, patients present with anemia or low platelets as a sign of the fact that the CLL has gone into the bone marrow. So when to treat, and this is, I think, is a central slide for patients with CLL because that's really, really difficult. And I spend a lot of time with my new patients. I hope I spend a lot of time with my new patients going through why certain patients will require treatment when they see me for the first time, whereas other patients don't. And this is really because of this classification that hasn't changed in 40 years. And I will show you the reason for this classification a little bit later, or one of the reasons at least. So basically, when you have stage A, BNA stage A CLL, it means that there's a lymphocytosis on the blood test, and that's it. There are no lymph nodes, there's no spleen that can be felt. We don't do CT scans. We don't do CT scans. There's basically nothing wrong with you apart from having a few more than normal lymphocytes in the full blood count. Then there is the BNA stage 2, where you do have areas of lymph gland swelling, and they need to be lymph glands that are of reasonable size and they feel like CLL lymph nodes. So you need like a CLL specialist really to make that assessment. GPs very often are not comfortable to make that assessment, and you might have got also a bit of a bit larger spleen than normal. That's what we call stage B, BNA stage B. BNA stage C is when you then have signs of anemia or low platelets called thrombocytopenia. So platelet count of less than 100 or a hemoglobin of less than 100 is a sort of definition of stage C CLL. And obviously that when it comes to stage C CLL, then usually patients will require treatment. Stage A doesn't normally require treatment. Stage B sometimes require treatment. The problem with the assessment of stage B disease, it's very grey, because when CLL patients get an infection or when they're in a bad mood or whatever, the lymph nodes might go up a bit and they might enlarge and then they go down again. And so we're seeing this a lot, that patients are observing this a lot on themselves once they've had CLL for some time, that things can go up and down. And so rushing into treating, somebody who comes through the door saying, oh, I had a bit of an increase in my lymph nodes, that wouldn't be the right thing to do. So we always wait. We call it watch and wait or active surveillance. We always wait, we remeasure the lymph nodes, and then we have another look at the patient. We look at the symptoms, if there are any. So we'd never go on the number of the lymphocytes in the blood. That's not one of the criteria to decide of whether a patient needs treatment or not. We go on anemia and low platelets, and we go on sort of progressive lymph node swelling over a longer period of time. And by that I mean sometimes a year, 2 years. The extreme I've had, I think, is a patient who basically said, I was really convinced she needed treatment within the next 6 months, and 3 years later she was still not requiring treatment. So it can be very grey and can actually be, depends a lot on how patients feel about having treatment as well. So the other thing I should say here, if you have read this here, obviously this is very historical, and we would just forget about it. The overall survival and data and figures that we have got in the literature at the moment are totally out of date, and I would just ignore them because of all the new therapies we have, and I come on to this in a little while. So I've already talked about this. So what means progressive disease? How do we define treatment indications? And despite of these definitions, it's actually a very grey area, and it requires a lot of discussion between the patient and the wishes of the patient and and the physician, because of course it also depends on how the patient feels about the treatment and whether he's very keen to have treatment or not keen at all. So about the general management then. So unfortunately, we don't see stage A patients regularly in a specialist consultant hematology environment. So stage A patients are usually discharged back to their GP. Sometimes they don't, often actually they don't even see a hematologist specialist. Now I'm not in favor of that system, of course, because I think that, you know, I think the tip of the iceberg of patients who insist on being referred to the hospital because they feel very uncomfortable with having just been told you've got leukemia, but it's okay, I see you in 6 months, and have GP follow-up. So this is getting increasingly, I think, you know, quite rightly so, you know, from what I hear from patients, you know, the patients are demanding to be seen by specialists. The problem we have is that we can't see all stage A patients because our clinics will be full with stage A patients and we haven't got the resource in the NHS. So that's essentially the main problem with it. We are looking at other ways, and some of my patients might be aware of a system called Patient Knows Best. So again, for these systems, they're essentially using clever web-based tools to communicate and improve communication with patients who are out there in the community, to give them access to specialist advice if they need it. They're obviously good, but they're really good, and I'm really convinced. But they're only good for patients who use the internet. If you don't use the internet and you are scared of, you know, using web-based tools, then that's not a solution. So I can see that over the next few years, with the increased pressure on NHS resource, I can see that these type of tools will gain a lot more acceptance. But I also see that that we need alternatives to you know, to web-based outpatient clinics, in particular for these patients who quite often, you know, feel very badly looked after by in primary care, because, you know, the GPs are very busy, and also they're not specialist hematologists. So so progressive stage A disease, I try not to treat whenever I can avoid it, because usually these are patients with an isolated lymphocytosis, and they are very fatigued, and they struggle a lot with their life. But the problem is that when you give chemotherapy in frontline, then it makes the patients even more fatigued, at least, you know, whilst they're going through therapy. So it can be very tricky to decide whether a progressive stage A patient should have treatment or not. In a lot of the other problem with it is that in a lot of the historical trials, progressive stage A patients were excluded from the clinical trials, so they weren't eligible to go into clinical trial, which means that the data on efficacy of some of the agents we have out there is not really there for progressive stage A patients. And so this means that as clinicians, we're usually a bit more reluctant to start treating patients just if they have an isolated lymphocytosis and reasonably non-specific symptoms like fatigue. White night sweats, drenching night sweats is the exception from the rule. And of course, you know, if patients have very significant weight loss, then I would also treat progressive stage A patients, but I would also, you know, exclude and try to exclude as much as I can other causes for the symptoms. So stable stage B disease patients require active surveillance, as I already said. Progressive stage B patients, usually when they have a, you know, persistent increase in their lymph node size or in their spleen size, I would usually treat within the year. And then stage C patients, of course, you always treat quite soonish. There's lots of other things that we should be doing in the general management of our patients, and I've just highlighted a few things there. So vaccination is one of the questions that comes up regularly. I know a lot of patients are not really in favor of vaccination. I have seen, when we had the flu epidemic a few years back, I've seen patients with CLL, I don't want to scare you, but I've seen patients dying on ITU with flu. Because they didn't have their vaccination. So the annual flu vaccination is really, really important, because patients with CLL, whether you are on treatment or not on treatment, you never had treatment, you don't want treatment, it doesn't really matter. Patients with CLL are immune suppressed. And so it's really important that, you know, that vaccinations are being taken seriously. I usually advise, you know, the annual flu vaccination, the pneumococcal vaccination, and then there are other vaccinations against meningococcus and Haemophilus influenza that are also very effective. in preventing very serious types of pneumonia. Now, that doesn't mean that you won't get pneumonia when you're vaccinated, but it decreases the risk per se, and it also decreases the severity per se of having a very serious infection. So I'm a real fan of vaccinations, I'm afraid. Now, the one exception from the rule are active vaccines. So, for example, at the moment, the shingle vaccine. Even if your GP says you should have it, because the GPs are going on advice by the Department of Health, and the Department of Health had forgotten to put into the advice not for immune suppressed patients. So the whole of Haematology has written to the Department of Health to say you have to amend your guidance because it does not apply to hematology patients who are on the one hand the ones who would be benefiting most from the shingle vaccine cannot have the current shingle vaccine because it's an active vaccine. So there are clinical trials ongoing to look at efficacy of inactive shingle vaccines, but these are now closed, and I haven't heard they're not available. These vaccines are not available on the market at the moment. So you need to really not have a shingle vaccine, I'm afraid. The only other active vaccine I think that is still around is yellow fever. So if you do decide to go into funny places in the southern hemisphere, then you do not have to have the yellow fever vaccination. Immunoglobulins. So in some patients, when they get recurrent infections, and this is another contentious issue in the NHS at the moment. So if you have had recurrent infections that led to hospital admissions in the last 6 months, or to one admission to ITU, and you're not responding to pneumococcal vaccination by measuring the antibody titers afterwards, and you still get infections because you have not responded to prophylactic antibiotics for the last 6 months, then you're eligible for immunoglobulins. And so we all think that these rules are too strict, and they're essentially based on some historical data on safety of immunoglobulins, but then primarily based on cost. And we think that this whole process should be accelerated for patients with CLL, because we see increasingly, particularly as patients with CLL live longer with the new agents, that they do get recurrent infections, and that their immunoglobulin levels, so the antibody levels that fight infections in the blood, those levels go really low. And you can replace them with immunoglobulins through a subcutaneous or drip infusion, and it works really well. But that treatment is at the moment, so it's basically controlled by a committee that decides, on an individual patient-by-patient basis whether you're allowed to have them or not. And so this is where it's getting really kind of complicated. And it's going to be increasingly complicated because patients live longer, and therefore there will be more and more patients. And so we need to find a better system. It's one of the areas, the emerging areas, I think that we will see a lot more work on in the next few years or so. So patients with CLL, unfortunately, also are at risk of other cancers, much more increased risk. Skin cancers is one of them. The risk of having any type of skin cancers is 20 times more elevated when you have CLL, which basically means that there's a reason why we say put sun cream on. Most of the time, these are very mild skin cancers, so basal cell carcinomas. They just need to be removed, and they're not that serious. But there can be more serious cancers as well, and the malignant melanoma is 7 times more frequent in patients with CLL. So it is really important to protect your skin. The other cancer that is more frequent is lung cancer. It's not quite clear whether this is because we do more CT scans on patients with CLL and therefore we detect more lung cancers, or whether this is really a proper link. But we do advise patients not to smoke. It's also important not to smoke because if you do get infections with CLL, because your immune system isn't 100%, then the chest is usually the weakest part of your body, and patients do run into trouble with chest infections and pneumonias, which is why we also ask for the vaccinations, and we ask patients not to smoke. So those are in a nutshell, the other really important advice that I give of things that you can actually do something about, and you can also get your GP to do the right things. there was something else I wanted to mention. Oh yeah, so there are some alternative things that you can do that I haven't put on the slide here, but there's a little bit of evidence that a green tea extract might work, vitamin D might work. Don't make a philosophy out of it. There's this very limited data, but it doesn't do any harm. You can't drink enough green tea. It's calculated it has to be 20 liters. You'd have to drink a day, and I find it very disgusting. So if you go to Holland and Ballard and you buy some capsules of green tea extract, that will do the trick. And then vitamin D, of course, you can also just buy. Vitamin D seems to be good for any type of cancer. So I just thought I'd give you a little, because it's another question that comes up a lot, and I put all of them in there. I think I've got enough, yep. Looks really complicated, but I think I'll talk you through really step by step. So this is essentially, so that we begin to understand a little bit better, how the different treatments are working. So you're looking inside a cell here. So this is the cell membrane. It's obviously a three-dimensional something, think of it like a football or something. Inside that football is another football, a smaller football. That's the cell nucleus. And inside that cell nucleus is all the genetic material, the DNA. And that's really what is the sort of the control room of the cell. Inside that cell are lots of things, and I won't go into them in detail, but the important things are the things that transmit signals that are coming from outside the cell to the inside of the cell, so that the control room can essentially, react to the outside stimuli in the outside world. So, this is the outside world. It's somewhere in a lymph node or in the bone marrow or in the blood. And then you've got all these antennae, which are essentially antigens, cell surface markers, like the CD20 that reacts with rituximab, for example. All these antigens and cell surface markers are sitting on the outside, and when they're being stimulated by another T cell or by an infection, then signals are transmitted to the inside. And it's these transmitting things, they're all proteins, these transmitting, or enzymes, these transmitting things, kinases they're called in the jargon as well, these transmitting things basically are things that we can target with treatments now. So we can target the outside, with antibodies that really fit very well to, for example, this cell surface marker CD20. So we've got rituximab, obinutuzumab, ofatumumab, all these antibodies, they're all directed against CD20. And then we've got signaling molecules and signaling proteins, and ibrutinib, idelalisib, they are directed against those signaling molecules. And then we've got chemotherapy, and chemotherapy is directed against the control room, so against the DNA, and it destroys the DNA, and thereby, the cell doesn't know what to do anymore, and it just dies. That's the theory. So what you can see from here is that the control room of a cell, whether it's a liver cell or a gut cell or a skin cell, the control room is always the same. But the outside, the cell surface markers, the signaling molecules, they are cell specific. And so the B cell has got very specific signaling molecules and cell surface markers. The chemotherapy will attack every cell in your body, in particular the cells that divide a lot, because it's attacking the control room. Whereas the other molecules, they only attack, to a large extent, only attack B cells specifically. And that's why we're talking about target bullet treatment, because these cell surface markers and the signaling molecules are very specific. And then there's a third way, fourth way already, of targeted therapy. That's not that targeted to B cells. It works because that also works in other leukemias, for example. But that's basically directed against the death pathway in the cell. So when the cell is not happy, usually it switches on a signal and then the cell dies. And so the problem with a BCL2 is that it prevents this switch from happening. So when you inhibit BCL2, the cells can die again. And that's basically, this sits in the something called the mitochondria. It's in another type of, the cell, essentially, another area of the cell. So it's the fourth way of targeting, CLL cells really effectively. And the fifth way has to do with the immune system. And there are different ways these days of doing this. Some of you might have heard of CAR T cells, cytotoxic T cells and engineering of T cells. Bone marrow transplantation, is the traditional form of immunotherapy, where you essentially activate in one way or the other, T cells. I mentioned that at the beginning of my talk, that the T cells help the B cells to fight infection and to fight cancer and to fight, all these different things. So the T cells essentially are being reactivated to fight cancer cells in one way or the other, whether this is through bone marrow transplantation, CAR T cells, or through the new checkpoint inhibitor therapies, nivolumab, you might have heard of. So there are new agents, now in solid tumors and also in lymphomas becoming available that look specifically at reactivating T cells. So there are 5 different ways now that we can treat CLL very effectively. Well, this is already inside. There are 3 additional other ways, so it's almost 8 different ways of attacking and tackling CLL. When I started as a registrar or even as a consultant, almost 10 years ago now in hematology, we only had this. And we were giving chlorambucil and fludarabine single agent. This was what we were doing in 2007. And now we've got all of these available, and most of these drugs are now NICE approved. So we have this is huge, this is a huge improvement. And the real question now is really whether, with any of these, or combination of these, whether we can cure patients with CLL. So before I come on to this, though, another word on heterogeneity. So you don't have to learn this by heart. I just put this up here to remind myself. But it's basically, there are some patients, very small group of patients, at the beginning of their life as a CLL patient, where they need, with an abnormality in the genes called TP53. And so whether you have a change in the TP53 DNA or whether you've just lost a copy of the gene of TP53 called a deletion, doesn't really matter. Whatever it is, it means that you don't respond to chemotherapy that well. And that's been demonstrated in multiple clinical trials, and we know that when you have got this abnormality, 17p deletion or TP53 mutation, we know that you don't benefit from chemotherapy. And now that we've got all these other agents, it's a no-brainer that we should look for this abnormality before giving patients chemo when we know it doesn't work. So in the nitty-gritty detail, what does it look like? So when you have, in your genes, you've got 46 chromosomes, 23 are from your mother, 23 are from your father. This is one of them, called the chromosome 17. Okay, this is one of them, and this is the other one. You've got 2 copies. When there's a bit missing, it's called a deletion, and that bit contains the gene TP53. So you've got a deletion of 17p. The majority of CLL patients in their CLL cells, they've got 1 deletion combined with a mutation on the other copy. Okay, they've got this scenario here. And then some patients also have no deletion, but they only have mutations. So the problem with that is, and that's why I'm telling you about it, most clinicians in the UK and across the world, they only have access to one technology called the FISH technology in their laboratories. So when they're asking for this abnormality to be tested, the laboratories will go off and they will do a FISH test, fluorescence in situ hybridization, so FISH, and what they will find is the deletion. So they will be picking up about 40–50% of the patients. Okay? They won't pick up those patients. And I've just shown you before that those patients do equally bad, with chemotherapy. So we've been going on for this forever and ever, with guidelines and everything, that all these patients should have something else done on top called Sanger sequencing or next generation sequencing, even better. So that we can detect the mutations and that we can detect the other 50% of patients. So if you're sitting in front of your clinician and the clinician says, yeah, I'm really glad you don't have the 17p deletion, you're going to ask him, well, do I have a mutation though? Have you checked for that as well? Because that's the other half. And it's so important that you as patients understand this. You know, I know it's complicated and it's genetics and it's horrifying and terrifying. My kids are terrified when I have to draw these things to them, and they give up after 2.5 seconds. But basically, it's really important because, clinicians, they're busy people. They will go off and they will just ask for the FISH. They might not even know whether their labs are doing FISH or Sanger sequencing or NGS, right? So it's really important. Yeah, I haven't got a slide on this. So the other thing that is really important, this is sort of where some of my research comes in. At the moment, we say, okay, Sanger is good, NGS is better. The guidelines are still saying Sanger sequencing because a lot of the diagnostic lab, they are not really set up to do next generation sequencing properly. This is a different technology. The thing with this different technology is that it detects lower levels of TP53. So if some of your cells, CLL cells, contain this mutation but others don't, the Sanger sequencing will miss it. Whereas and that actually happens in, not infrequently, another 10-15% of patients. So what you really want is to have a really sensitive mutation technology, but that is validated, and a test that looks for the deletion. So it's quite complicated. We can talk about it after the talk. It's really important because the precision, if we're talking about precision diagnostics, this is what it's about. It's about the nitty-gritty detail. Yeah, you can do diagnostics like this, and you get it right 50% of the time, and that's fine. It's not good enough if you want to establish whether a drug is really effective or if you want to be giving really the right treatment for the right patient at the right time. Your diagnostic test has to be really precise. And that's where obviously my interest is with molecular diagnostics. So switching slightly, so coming on to the management now and the treatment. So watch and wait versus early treatment, something that patients find really difficult to get their head around. I have to say, me as a clinician, I find it increasingly difficult to get my head around because it doesn't make sense to sit there for years and years and years to wait for patients to progress, to get clonal evolution, and then to say, at the end, oh yeah, it's not curative. So having said that, this is offline. The official evidence suggests, which dates back from the late 90s, and which used chlorambucil or chlorambucil plus prednisolone as the sort of treatment, which is the most ineffective treatment that you can think of, but it was the only treatment available at the time, so it was a good study. These studies were both published in the New England Journal of Medicine, very high impact journal. Essentially what they showed was whether you get treatment at diagnosis or whether you don't get treatment at diagnosis and only get treatment when you need it, i.e. when you fulfill the criteria, you do the same. So early treatment didn't make the slightest difference to overall survival. Now, I think everybody would say that this is probably because the treatment was ineffective in the first place, right? But it's the only evidence we have. That's the problem. So there's some more evidence that the Germans are collating because they had a study a few years ago. That study is still ongoing. It takes forever to get the overall survival data. So we will have it, but it will take a few more years. And actually, the treatment they're using, FCR, was probably not the right treatment because you have to do these studies with the new agents like Ibrutinib and so on. So, it'll be 20 years before we have any kind of evidence on this one, I'm afraid. I'll be long retired by then. So why are we giving patients in frontline FCR when they're fit and don't have any other health problems? This is the CLLSA study, so just to go through this is always the time it takes to either progress or the time it takes to die for patients. And then this is the, all the patients and how they're doing. So you can see here that, the green curve looks much better than the blue curve. What that means is essentially that when you're adding rituximab to the chemotherapy backbone, fludarabine and cyclophosphamide, you do much better. The CLL stays away for much longer, and also you live longer. And this was the first study that showed conclusively an improvement in overall survival. It wasn't a big improvement, but it's a definite improvement in overall survival. So this is why FCR treatment is so was immediately NICE approved because it was the first time ever that we could change the natural history of CLL. A lot of clinicians are fans of bendamustine and rituximab, and I won't go through the detail, but bendamustine and rituximab is probably a good alternative for patients if they cannot tolerate, if the clinicians decide you cannot tolerate FCR treatment because your kidneys are not 100% or you've got this and that and the other. It's probably a good alternative. It's also a good alternative in patients who are that bit older. Patients get fewer admissions to hospital with bendamustine for infections. With FCR treatment, 25% of patients come into hospital with infections during the 6 months of treatment. So, FCR, the most aggressive treatment, also the most effective chemo. Bendamustine, almost equally good, less aggressive, fewer side effects, but not really considered as being the gold standard. It's also not NICE approved, which is another sort of hurdle. And then for patients who are a little bit frailer or have got other disease problems, other problems with their health, there are two NICE approved combinations. One is cloambucil with ofatumumab, and the other one is cloambucil with obinutuzumab. I've already mentioned to you ofatumumab, obinutuzumab, rituximab. They all target the cell surface marker CD20, on the surface of the cell. Remember the cartoon. They work slightly differently. The ofatumumab combination is really well tolerated. It's a bit like rituximab. You get few infusion-related side effects, but that's about it. And the CLL stays away for about 2 years, and the symptoms improve. The obinutuzumab also has been shown to lead to an overall survival improvement. So in our clinical brains, we think about cloambucil and obinutuzumab as a better combination to cloambucil and ofatumumab. However, the main downside of obinutuzumab is the infusion-related reactions, and they are very significant. So when you're first time having an infusion of obinutuzumab, there's a high risk that you get severe shivers and shakes, and that you might not tolerate it well. And so there are some patients where really, I think that actually, the ofatumumab is the better drug for them. But in terms of pure efficacy, obinutuzumab cloambucil is a good combination, and should be the preferred combination. But both of them are NICE approved. So this is in frontline. Patients who've never had any treatment. That's what we have on offer on the NHS. It's FCR, BR, bendamustine, rituximab, cloambucil, obinutuzumab, cloambucil, ofatumumab. It's a lot of choice. There is, however, also ibrutinib. Ibrutinib has got a license, so one of those targeted agents that specifically targets the signaling pathways inside the cell and leaves the rest of the body intact because it's a B-cell specific signaling pathway. The problem with this is that it's not NICE approved and that nobody funds it in the UK in first-line treatment. So that's the problem with ibrutinib. The reason why this is because in the study that the company organized, they decided to use cloambucil single agent as the comparator. And I've just said to you, this cloambucil has been around since the late 90s and is the most ineffective drug you can think of. Why have they used this as a comparator? Because it would never go through NICE or any official approval processes with this type of comparator. So, but essentially that's where we are. You can see that in terms of overall survival, big advantage. In terms of progression-free survival, big advantage. We have a little bit more follow-up data now, a 3-year follow-up data. The curve is not going anywhere close to the bottom. So what this tells you is that patients who have never had treatment and go on single-agent ibrutinib, they will go on for a long, long time without the CLL coming back. And that's really quite interesting data because, you have to remember that, a lot of those patients are a little bit older, and you might actually run into health problems down here sometime. If I extrapolate this 10 years down the line, it might not matter so much whether your CLL is coming back because it might actually be that you've had a heart attack in the meantime or, died peacefully in your bed. So I think it's kind of, it puts it into perspective. It's not NICE approved and we can't get it on the NHS. in the UK. All the other European countries and the US are prescribing Ibrutinib, in particular in the older patients, because it's so well tolerated. So, and then there's obviously the relapsed CLL patients. It's a very small proportion of patients, but of overall patients, and they're the patients with the 17p abnormalities. And you can see from the curves that, whether you're using Ibrutinib or Idelalisib, these new agents work really, really well in relapse setting. They work really, really well in high-risk patients. And they've really transformed the way we are treating patients with CLL in the modern world. You can see here from this is it's not a clinical trial, it's basically sort of cumulative data, four-year follow-up data on patients on Ibrutinib. And you can see from this here, this is the curve, it's the other way around, so I'll just kind of explain it to you. But it's basically within 4 years, only 20% of patients have come off Ibrutinib. And this is also includes also relapsed patients. So that means that the patients are doing really, really well on Ibrutinib. And the majority of patients who will discontinue in the initial 2 years is because of side effects of Ibrutinib, and it's not because of CLL progression. So, and the Ibrutinib works really, and in fact Idelalisib as well. I'm just there's a lot more data on Ibrutinib now, so I tend to talk about Ibrutinib, but it works really, really quickly. So this is a patient who had very bulky disease, axillary lymph nodes. Within a week, he photographed himself on the iPhone. They were almost gone. Within 2 weeks, they were completely gone. We do CT scans after 3 months just to objectively document responses. But this was a patient who's relapsed within 1 year of having had FCR treatment. So he clearly didn't have a good response. He doesn't have a TP53 abnormality, but half of the patients who don't respond well to FCR treatment don't have that abnormality. So he relapsed really quickly after FCR. He's been in remission now for, I think, about 2 years on Ibrutinib. A year, sorry. So then there's the third drug, Vanetta. And again, I said to you, this is another mechanism. So it's the fourth mechanism, is a BCL2 inhibitor, and it works equally well in patients without the 17p or TP53 abnormality to the patients with the abnormality. So in the last couple of minutes, I just want to talk a little bit about UK-based research. And obviously, I couldn't give this talk without talking about the Flair Study. So the Flair Study is basically a big multi-center study. It's led by Pete Hillman from Leeds, who's been our wonderful chair in the CLL clinical research group from the NCRN group. We've basically designed we designed this study a couple of years ago now. It started. Initially, half of all patients received FCR treatment, and the other half received Ibrutinib single agent. And very recently, during the summer, there was an amendment that came out where basically another 2 arms have been opened. So we are now having 4 arms. 3 of those arms are chemotherapy-free: Ibrutinib, rituximab, Ibrutinib single agent, Ibrutinib venetoclax. And then there's 1 arm still with FCR treatment. So it's the computer that decides, in which arm you're going. It's only open for patients who've never had any treatment. And then patients will have either 6 months of FCR, as you would normally have on the NHS, that's the gold standard, or you have one of those 3 trial combinations. And you will stay on those trial combinations until the CLL comes back. I mean, at the moment it says in the protocol for 6 to 7 years. If you do become at some point negative in the blood from minimal residual disease, so that's a very sensitive measure of whether the CLL is still there, we then do a bone marrow test, and if that's negative for minimal residual disease, we will then stop the treatment and just monitor to see whether the CLL comes back. And if the CLL comes back, you'll then be going back on those onto your treatment, and if it doesn't come back, you'll stay off it. So what you can see from the study design is that we are asking the question of cure here. Yeah, so, are we curing patients on these new, if we're giving it in frontline, are we curing at least some of those patients? Is minimal residual disease a surrogate marker of cure? If you're negative for minimal residual disease, is that a marker of cure? Do we need other markers of cure? So that's where the sort of the research around the Flair study comes in. And I think, I'd be pretty hopeful that not all patients, but that some patients will be completely cured. I also think that there'll be some patients who will be functionally cured. And by that I mean that they will have remissions that are so long, or they're very happy on the tablets, they tolerate them well, they take them regularly, and actually they won't relapse. So are they cured? They're not cured because they're on a tablet. But does it matter? No, it doesn't matter because they're actually free of CLL. So that's what we call functional cure. So I think this is a very good study. All my patients, if they're eligible, go into the study. The eligibility criteria are very open. The main problem with this is, like with any clinical trial, if you've had other cancers, then unfortunately you're not eligible. Or if you're really afraid of bone marrow tests, then we can't do this assessment. And that's really, really, it is a really important assessment on the study. So the other thing that we've been doing in the UK, rightly or wrongly, is the 100,000 Genome Project. And so I've been very heavily involved with this. This came along about 3 years ago now. The Department of Health essentially decided, well, we've got so much information now coming from research about how cancers are genetic disease, acquired genetic diseases. So it's basically the control room that becomes abnormal in the CLL cells or in the B cells, not in your germ line, not in your ovaries or not in your sperms, but in the CLL cells themselves. And that genetic information is the basis of everything. So if we are detecting all the changes in the genes and in the DNA, we would then be able to predict, treatment, new treatments, response to treatments, all these different things. So that's essentially what's behind it. And the Department of Health has put in, a lot of money to get this, get genomic testing and genetic testing being made available to the whole to all initially English patients. This has now been extended to Scotland as well. So again, a little bit of biology. So this is the cell, this time, just a picture through the microscope, so only 2 dimensions, not 3 dimensions as in the cartoon. The red blob is the nucleus. This is a CLL cell, so the kind of purple thing, lilac kind of color around it, that's the cytoplasm. The CLL cell has a very big nucleus in compared to the cytoplasm. Inside this nucleus is the DNA. And the DNA essentially is sort of normally packed up in the chromosomes, and it's really folded and packed again in multiple packages. But then when you unpack it, it would be, I think it's kind of several kilometers long, actually, what is in the cell, if you unpack it. But basically, it's is then the genetic code. So you've got G, T, C's, and A's, and they correspond to different nucleic acids. And that's really what defines us as individuals, and it also defines the CLL cells. So basically, you can have different changes. You can either have the G becoming a T, or the G becoming a C, or the G becoming an A. We call that a mutation, or point mutation, strictly speaking, or you can have bits of the chromosome missing, like with a 17 P deletion. I don't know why it's doing this. So if it's a deletion, obviously you've got bits of a chromosome missing. It's a different type of a mutation. Sometimes you can have a bit of a chromosome going to another chromosome, and we would call that a translocation. So the problem we have, as I've already alluded to, with the current diagnostic technologies is that they're either very good at detecting this, or they're good at detecting this. They're usually not very good at detecting translocations, and they can't detect everything in one go. And the everything in one go is both the different types of mutations, but then it's also where they are exactly in the genome. And I won't go into the details of that, but whole genome sequencing essentially means that you sequence 100% of the genome. Whereas what we normally do with with single gene sequencing is we sequence 1% of one gene of the 20,000 genes we have in the genome. So we're sequencing 0.0000001%, of the genome, or even less than that. So the technology that we're using in the genome program is whole genome sequencing. So we're sequencing everything. We don't know what 98% of it means. And that's the research part, and it goes into a big data center in Wiltshire. But the other 2% we can look at, and we can basically say, well, actually, does that particular change make a difference to patient outcome? Does it mean that those patients respond better to chemo or less well to chemo? Does it mean that they need Ibrutinib or they don't need Ibrutinib? So this is essentially the sort of questions that we will be asking as part of the 100,000 Genome Project. Every patient who goes into the Flair Study will be offered to go into the 100,000 Genome Project. So it's really the aim of this project is to identify the best of existing treatments, to provide prognostic information, so understanding better who are the patients who might not ever need any treatment. It provides a big data set for researchers so that we can study the biology and that we can identify also new therapeutic targets. I've spoken about 5 of them just in CLL, but there are many, many more inside a cell potentially. But we will only identify those if we identify the changes that occur in the CLL cells. So to finish off, the Genomics England program has teamed up with NHS England, and so we're essentially one of 13 genomic medicine centres who are recruiting patients into this program. This is not just about CLL, it's about all solid tumours, it's about all patients with rare diseases as well, family with rare diseases. So the local centres, local delivery partners for Oxford are these hospitals here, and they should be sending us samples from CLL patients and also for other patients with cancers into Oxford, where we are then preparing the DNA in the lab, and then it's going off to a sequencing centre. It's a big team behind this, as you might imagine, and these are the people who are currently leading and dealing with the operations of the project just in Oxford. There's a website, I haven't got a copy here, but if you have an interest in this, there's a lot of patient information, there's videos, there's sort of interactive stuff on the Genomics England website if you want to Google Genomics England. And I think that's all I have to say. Any questions, let me know. Yes, so
I know it's an academic question.
no. So, but it's a really important question, and it's. I think maybe I'll go on this slide because I skipped that slide in the interest of time. So basically, you've got the control room and the DNA in your ovaries and in your sperms, and that's what you inherit. That's what you give to your offspring and to your children, and what you inherit from your parents. And then you've got in each cell in your body, you've got the same control room. And if the mutation occurs in any one of those cells, so for example in a B cell, then that might trigger CLL. So what it means is that you were not born with a 13q abnormality. Essentially, it means that you acquired the 13q abnormality in your B cells at some point. We do not know why. And then once you've acquired the abnormality, it might then trigger you to get CLL. So it's a stepwise process. Quite often, so the 13q abnormality is the most common abnormality, and it's in CLL. Over half of the patients have got the 13q abnormality. If it's isolated, it confers an extremely good prognosis. But in order to see whether it's isolated, you have to do whole genome sequencing, strictly speaking. So people are often saying, oh, isolated 13q abnormality, but you can only know whether it's isolated once you've done, you've looked at the whole genome. Certainly, if you don't have, an 11q and 17p, and you don't have any of the mutations, then it's usually suggestive that you have a very good prognosis. But these are the sort of things that we are currently not using in the clinic because we haven't got the evidence. And it's the sort of thing that when you do whole genome sequencing systematically as part of a clinical trial, you will get that evidence eventually. So it's one of the very intriguing things, because if we had a way of saying upfront to all patients with CLL who have just been diagnosed with CLL, but you will not require any treatment, that would be really cool, wouldn't it? Yeah. So.
And Ben Kennedy at Leicester.
Yes.
And,
oh yes. Yeah. Well, he's very good. You're in good hands.
he's told me about him.
Yeah. Very, very good. Put my glasses on.
At the back, yes. Go ahead.
I've written for first-line patients. How many of those are progressing, in terms of cognitive failure? Their
Yes.
disease has progressed. How many of those are?
Yeah, very few. I mean, I showed the slides the other way around, but basically, just try and go back to them.
And when they do, is it due to kinase mutations?
Yeah, so I mean, basically, this is sort of relapse patients and frontline patients confounded, but you can see that the main reason for what they call other events in the first 3-4 years really is not CLL progression. This is the curve for CLL progression. So very few patients will progress. Most of the patients, they come off the drug because of side effects, primarily either bleeding or irregular heart rate or high blood pressure. Those are the things that you stumble across when you go on Ibrutinib, and some patients are just unlucky, and and they have to come off the drug. In the Frontline study, hardly anybody. Just having a look what I can find. Yeah. So in the Frontline study, as you can see, there's very few patients have come off, and the 3-year has even flattened out more. So the patients very few patients come off because of resistance in frontline so far. But the ones who do, and also in the relapse setting, you're right, they do have mutations in this signaling pathway that makes, in particular in BTK, that makes the drug no longer stick so well to BTK, and therefore it can't inhibit BTK anymore.
Yes, question here.
Quite early on in your presentation, you were talking about the different ways of responding to people who were in progressive stage A patients and those who were in stage B, that were static and so on. And I'm really wanting to ask you, in your capacity as chair of the forum, to what extent, and you mentioned the issue of resources at that point specifically, and that you don't have the resources to monitor static stage A patients and so on, which actually is not my experience. But I just want to ask you to what extent you think, from your work as chair of the forum, that there's an element of postcode lottery in the way in which different trusts are dealing with this disease. And I ask it because if it is the case, and it might be or it might not, but if it is the case, that suggests certain strategies which the CLLA Support Association should be pursuing.
Yes. Yeah, I mean, I agree. We are rewriting the guidelines at the moment with the CLL Forum. So as the chair of the forum, I'm kind of responsible for that, and we are in the later stages of the rewrite. I think we will say very strongly in there that patients with CLL, irrespective of what stage they are in, should be looked after by a specialist. But the question is, of course, what it means looked after, and whether that includes web-based tools or whether it includes seeing patients, in clinic, and how often they should be seen. So there's a lot of nitty-gritty details, and I agree with you that there is variation across the country around what people do and how services are set up. There's also postcode diagnostics, which again the NHS England are very aware of, and they're trying to address this with the 100,000 genome program eventually, because there are discussions ongoing now within NHS England and the commissioners that cancer testing, genomic cancer testing across the board, not just for CLL, should be made much more widely available and should be standardized across the NHS. Because there is a lot of postcode diagnostics going on, not necessarily because the clinicians don't want to do the diagnostics, is mainly because the services are not necessarily set up in a way that you can send off a blood test on the CLL patients to a lab and get all the right results back very easily. So.
Sorry, this lady, you mentioned skin cancer and CLL, but you didn't mention perhaps the path to skin cancer. Is there a link basically between actinic keratosis, then the squamous cell, and then what it goes on to from there, which name escapes me, and then going on ultimately to melanoma, I suppose, and CLL? Does one trigger the other?
No, then they don't trigger each other. There's just an association. So what that means is that when you have got CLL, you've got a much higher risk of getting or of having already had skin cancer of any or in any shape or form. Of course, all skin cancers have got are more frequent with sun exposure. So whether it's the basal cell or Bowen's disease, or squamous or melanoma, you always have to protect your skin against the sun.
So you're just more vulnerable.
You're just more vulnerable. Yeah, it's not a trigger.
Yes.
Is it possible my brachytherapy treatment could cause CLL?
Your what?
Brachytherapy.
I mean, it's impossible to say, really. It's impossible to say. But, if you do need treatment, is one of the other sort of hot topics at the moment in oncology. Is that, it's all very well to say, well, chemotherapy induces more damage, and probably it does. But if you do need treatment for another cancer, then you'll clearly have to have that treatment. So I think these arguments become more relevant when you've got an alternative to chemotherapy. And this is where clearly with CLL and Ibrutinib in frontline, the discussion is quite interesting because you do have an alternative. If we didn't have an alternative to chemotherapy, we wouldn't be discussing the complications and the risks of chemotherapy.
Is Ibrutinib not available on NHS on the grounds of cost, and is those costs of drug likely to come down in the future?
Yeah, I think it's a good question. I don't actually know exactly when Ibrutinib's patent runs out, but I think it's another almost 10 years or so before it does. You're right. I mean, it's a question of cost, because there's an awful lot of patients who need frontline therapy for CLL. There's a lot fewer patients who need it at relapse. So the sheer numbers of patients wouldn't allow the Ibrutinib to be funded in frontline. NICE didn't even look at this because the company didn't even submit it because they didn't want to have the discussions about reducing the price for the drug. So I think if Ibrutinib was a lot cheaper, then it would be considered. Yes.
I think we'll now pass to the written questions. One
Yeah.
has been handed here for you. By the way, I have heard while I was looking at the questions to get an idea of an overview of the questions you've asked on paper. I have heard that it's the actual microphones that are on you, passing to you, Anna, that are causing the crackle, and that this is a better system. So we're going to try that.
Right. So I'm just trying to. Sorry. Is this?
Try this instead.
Is this even? I didn't hear any crackers with this one. Okay. No, I think this one he needs. I think. Yeah, he needs that one. Okay, so there's one question about genomics and prognostics. When we can use patient genomics, when it will be available to help with prognostics. Yes. It refers to the thing I said early on. I think it would really depend on, how quickly we can get, genomic testing, genetic testing being made available across the board to a lot of patients in the NHS, and that will depend on, the drop in price again, of the way we're currently doing genomic sequencing. So the genomic testing is still, whole genome sequencing is still quite expensive.
If you put the money to one side then, if there was limitless money, what would the answer be?
If there was limited less money available, I think yes, 3 to 4 years, yes, because the technology is there, and the data for making it valid and so on is becoming available, is being generated across the world at the moment. So it's really literally again down to cost. And because the main sequencing provider, I don't want to go too much into details of that, is just a single company at the moment, and they have a monopoly, so they don't have an interest in reducing the cost. Once there's a second competitor, then it will be cheaper to do whole genome sequencing than doing current fish testing. That's what I'm predicting. Okay.
Third pair of hands.
I need to read the question first. Yeah, so there's a question on the side effects after FCR therapy when you had sort of extreme reactions after minor insect bites or blisters. Yeah, I mean the bottom line is all these things. Usually we say to patients they get better when you've had therapy, the chemotherapy, but it can take. I would say probably can take about a year before your skin and your whole body system is back to normal after you've had chemotherapy. In particular, FCR therapy can hang around in this, or the effects of it can hang around in the system for a long time. I wouldn't expect it to be going on forever though. So any kind of problems with skin, related reactions a long time after chemotherapy, I would assume that they are independent of the chemotherapy. A lot of patients complain about dry skin as well after chemo. They get funny rashes. You're more prone to getting fungal infections as well after. So if you get really itchy skin, make sure that it's not a fungus. The amount of green tea extract tablets. Yeah. Yes. Yes, no, this is so I think I've settled on maybe having 2 capsules a day. I mean, it depends obviously what you're buying from Holland & Barrett, and that might change. But I would go with whatever is advised on the box rather than sort of, taking a whole box a day, because, but it does boil down to the fact that the Mayo Clinic study was based on a big amount, a huge amount, that you couldn't possibly drink. And that the extract tablets, I believe, that are currently available from Holland & Barrett also contain far less green tea extract than what the Mayo Clinic used. But then, the Mayo Clinic did the trial, I think, over a year or so, a couple of years, whereas you might be taking the green tea extract for 10 years. So the cumulative dose might actually be getting close to the Mayo Clinic dose. There's no right or wrong. I don't think they didn't get any more funding to run a subsequent study, unfortunately, on this, which is why we might never find out. So why have an NGS multigene panel if the results will never affect an individual patient's treatment, just for trial population interaction? Yeah, so I think what I've been trying to say so far is that the conventional prognostic markers that we've identified in the past weren't strong enough to predict individual patients' treatment. I think this might actually change with the genetic testing. So the vast majority of the other markers that are out there, prognostic markers, are not really genomic or genetic markers. And I do believe that if you have now that we have got the technology to look at the control room, I think that will give us the strongest predictive power. But clearly the NGS multigene panel isn't the right solution, and looking at immunoglobulin rearrangement isn't in a very targeted way isn't also, hasn't been good enough. So I think, we think we do need to look at the whole genome and the whole control room, in its entirety. And then we still might say, well, we can't predict it, in which case we're stuck. Well, I will be stuck. Any additional drugs, treatments available privately other than NHS? Yes. So, I mean, there's always other routes for treatment. So in Frontline, we can prescribe privately anything that has a license. Because Ibrutinib in Frontline has got a license, you can, get access to it if you have private insurance. Clearly, it's a very expensive drug, and you wouldn't want to pay for it. I wouldn't think that was reasonable. But if you have private insurance and it's covering Ibrutinib in Frontline, then that's definitely an option. There's also always other options for patients with relapsed disease. We do have run a lot of clinical trials across the nation, also here in Oxford. At the moment, it's been quiet for a little while, but we had the Clarity study, for example, a very nice study combining Ibrutinib and Venetoclax in patients with relapsed CLL. So there you get access to 2 agents in the relapsed setting. That study is now closed to recruitment, but clearly very promising, drug combination. And there will be other combinations coming through the system on the back of the trial acceleration program that Bloodwise is funding. There's also some commercial studies, early phase studies, looking at new agents, totally new agents, and they come and go, these studies. So, but there is a regular trickle of new and very promising therapies coming through. So who is eligible for the Flair study? As I said, the inclusion criteria are fairly open. You do need to be fit enough to have FCR therapy, because one of the arms is still FCR. So if you do have significant kidney function problems, then I tend not to offer the study to patients. If you've got very significant other comorbidities, I wouldn't offer the study. Because of the risk of having one of the arms still being FCR therapy. So if I think patients have a frail heart and might not tolerate a serious infection very well, then obviously the Flair study might not be the best study, just because of the FCR as the 4th arm still being in there. We do think that as the Flair study evolves and it's being continually amended, that at some point the FCR arm will drop. And that will then open the inclusion criteria up to patients who are, maybe no longer 25 and who have got other comorbidities, because we think that the other combinations, Ibrutinib, Venetoclax, or Ibrutinib, rituximab, or Ibrutinib single agent, that they're obviously also very tolerable for older patients or patients with comorbidities. So the Flair is an adaptive trial design, and it will change over time. When the FCR arm stops, we will have a lot more patients will be able to go into Flair. And then the only other significant exclusion criteria, as I already mentioned, is if you've had previous cancers. And that's really to make sure that we are not recruiting patients who might have a poor prognosis for other reasons, and who will then, on the paper at the end in the analysis, it then looks like a lot of patients have died on the study. And it's then in the overall survival, everybody who dies will be included. That's how studies are reported, and that then means then that it looks like the CLL treatment was really bad. And so therefore, for in any studies in oncology, patients with previous histories of cancers are usually excluded from studies. Please clarify who's eligible for treatment using Ibrutinib. Yes, so in terms of the NICE guidance, it's everybody who relapses within 3 years of having had chemoimmunotherapy. So anybody who's relapsed, who has a very short or reasonably short time, after FCR treatment, after bendamustine rituximab treatment, even after chlorambucil or ofatumumab treatment, for as long as they've had an antibody and chemo, and then they relapse within 3 years, they're eligible for Ibrutinib therapy. They're also eligible if the clinician thinks that they're no longer fit enough for further chemoimmunotherapy. So frail patients, who might have only had cloambucil in frontline, when they relapse, they're eligible for ibrutinib therapy. It's they're actually, NICE was very open in the way this is prescribed in relapse. And then obviously patients with 17p abnormality or TP53 abnormality, they're eligible in frontline because we know chemo doesn't work. So for that group of patients, which is a very small group of patients, NICE also approved ibrutinib in frontline. I think those were the questions. Yeah, I think so. Oh, this one. No, this one haven't. It's on a different piece of paper, that's why. High dosing of vitamins. Oh my God, can oxygen chambers help? Oh my God. I'm not a specialist in either of them, I have to say. I tend to say that you should take the amount of vitamins and tablets that's written on the box, because you don't want to overdo it. You do actually can get side effects from vitamin C, for example, if you're overdosing yourself. It's quite difficult to overdose, but you can overdose. So I wouldn't. I would always stick to the amount that is written on the box, which is usually an amount that you would already take in of that vitamin as part of your daily allowance and your daily normal diet. Oxygen chamber, I've got absolutely no idea, to be honest. Maybe something to explore in future. Okay. Yeah, thanks. Thanks for having me.